Hello, everyone. I'm Ann Mertlow, President and CEO of United Way of Central Indiana, and I want to welcome you to our session this evening. We're here today because United Way is committed to diversity, equity, and inclusion in everything we do. We're experiencing one of the greatest struggles of a generation. While we're fighting a deadly virus that's killing people and crippling our economy, we're also fighting an even older disease, racism, that is still killing people, causing enormous injustices, and preventing neighbors from succeeding in life. At United Way, we are hard at work eliminating barriers that prevent people from achieving their full potential. Our vision is that Central Indiana is a place where we're proud of the quality of life of all of our residents. We know that is not the case today. In fact, before the current COVID-induced economic crisis, our research showed that there were 216,000 Central Indiana households struggling to make ends meet. Households disproportionately represented by individuals and families of color. In fact, in every one of the 6 counties our United Way serves, the number of Black and Brown struggling households were increasing, while the number of white struggling households were either holding steady or decreasing. We'll have to wait for the post-COVID data, but I suspect this is now much worse, given that Black employees are disproportionately represented in the job sectors that were hit hardest and earliest when COVID shut down the economy earlier this year. Racism is a significant barrier to success, and its roots are deep. That's why we've convened this educational series, Understanding the Roots of Racism, a 4-part series on how inequities and injustices in policies and practices of the past have created barriers to services, resources, and opportunities for Black Americans, many of which still exist today. Today's session covers health. The next 3 will cover housing, food insecurity, and transportation, and will be held on the 3rd Wednesdays of August, September, and October, respectively. Our hope is that we'll all be more informed and therefore more empowered to act after these sessions, and that together we can better live united in a way that achieves our vision for a community that truly benefits all who live here. I'm here to learn, and I hope you are too. Thank you for being on this journey with us. At this time, I would like to introduce our moderator for tonight's panel, United Way of Central Indiana's Vice President of Impact Research and Analytics, Denise Lester.
Thank you, Ann, and welcome everyone. As mentioned, my name is Denise Lester, and I'm the Vice President of Research here at United Way of Central Indiana, and the moderator for today's discussion. I'm honored to be here with you in the distinguished panel as we kick off our series, Understanding the Roots of Racism, and confront the alarming racial and ethnic disparities within our healthcare system, and learn more about where the inequalities derive from. Today's Understanding the Roots of Racism discussion comes at a time of America's awakening on racial justice. As many in our community work to bring about structural change, including addressing criminal justice reform in America, we are also faced with a public health crisis that is disproportionately afflicting communities of color. We have long known that people of color experience disparities in healthcare in the United States. While we have made progress to help lower the African American, to close these gaps in recent years, including the passage of the Affordable Care Act, which has helped lower the African American uninsured rate by more than 1/3. People of color in America continue to experience disparities in care and worse health outcomes compared to white Americans. Long-standing systemic health and social inequalities have put some members of racial and ethnic minority groups at increased risk of getting COVID-19 and other severe illnesses, regardless of their age. African Americans are 5 times more likely to contract COVID-19 than whites. Black Americans are more than likely to die from heart disease or stroke at a young age. Black mothers are 3.5 times more likely to die during childbirth, even when they have higher incomes and more education than their white counterparts. In addition, high costs continue to limit access to health care for African American families who spend nearly 20% of their household income on healthcare premiums and out-of-pocket costs compared with a national average of 11%. We know that many of these families are ALICE, asset limited, income constrained, but employed, also known as the working poor. Families who are one emergency away from slipping into complete poverty. In Central Indiana, 34% of the entire population, or 216,000 households, not just individuals, but households, are ALICE in poverty. And the COVID-19 pandemic is steadily pushing these numbers higher. Over the next hour, I'm hopeful we would take a step forward to better understand and address these heartbreaking disparities and inequalities. I am honored to be the moderator for today's distinguished panelists and to thank them for joining us to share their experience and their expertise and their life experience. It is my pleasure to introduce Senator Jean Breaux, Indiana State Senator, District 34, Dr. Virginia Kane, Director of Marion County Public Health Department, Carl Ellison, President and CEO of the Minority Health Coalition, Dr. Ram Yaleti, Chief Physician, Executive, Community Health Network. And each of our four panelists tonight are so accomplished that we do not have time to even provide a short biography, but please look for a link in an upcoming email to learn more about all they have done locally and for the state of Indiana. Let's get started. Our first question: what historical events have impacted the current state of health outcomes for Black people living in the United States, Indiana, and Indianapolis? We'll start with Dr. Kane.
Oh, I'm muted, 1 second. Can you hear me?
Yes.
Okay. I would have to say probably the most famous study in this country related to racism was the Tuskegee syphilis study. Back in 1932, where over 600 sharecroppers from Tuskegee, Alabama, in combination with Tuskegee University, a historically Black institution, partnered with the U.S. Public Health Service to look at the natural history of syphilis in African American men. Now, at that time, in 1932, we didn't really have a good treatment for syphilis. It did not happen until 1947. But the study went on from 1932 to 1972, where the workers were told, hey, enroll in the study and we will provide you free medical care. And you've got bad blood, is what they described it. They never said it was syphilis. They didn't tell them what their diagnosis was, but we will treat your bad blood. And so what happened, they would get placebo pills, not real pills. And even when syphilis was the treatment for syphilis, which was penicillin, at that time would treat it, take away their infection. They were never offered it during that time. So you had over about 400 of these men eventually died from syphilis in their brain or syphilis in their heart. They infected over about 50 of their wives or girlfriends. This led to a significant number of congenital syphilis, where you had deformities related to the congenital syphilis. Babies would be born with a smashed nose. Their teeth would appear crooked and uneven in their sizes. And this went through 3 generations. If you never treated it, it would pass down from mother to her children and her children after that. So the inhumanity related to this, when they had a treatment, they allowed all of these men, for what they said on the nature of science, that this was all right. And at that time, at that era, all of us didn't necessarily were able to read, so they couldn't even know by reading the papers what was going on with them. So this has led to tremendous amount of mistrust with government. And when we went to HIV/AIDS, a lot of people assumed that the US government was actually injecting Black Americans with the HIV virus. So we wonder sometimes over years, traditionally, how difficult it is to sometimes encourage and motivate people to get preventive care when our healthcare system has used us as guinea pigs sometimes. And so, can we be safe now, is what they ask.
Thank you, Dr. King. Carl? Unmute.
You remuted.
All right, I'm good now. Okay.
Yes.
All right. I'm sorry. We'll continue with what Jenny has to say. It is clear that our legacy of slavery, our legacy of legal discrimination, our legacy of limited access to care, and frankly, the living environment in which African Americans and other marginalized populations have lived all contribute to circumstances which lend themselves to poor health outcomes. It's amazing to me sometimes that particularly younger people don't know that somebody like me actually lived in legal segregation. I was born in the South. So I remember riding the back of the bus. I remember going to a color-only fountain. I remember having to be in the balcony to go to the movies. I remember the injustices of man. And so as a society, our injustices toward populations of color are historic, they're deep, they're significant, they're still felt. And sometimes it appears that we're in a society where other folks just don't see or hear what's perfectly obvious to us. So we have a legacy that led us to where we are today.
Thank you. Dr. Yaletti?
There's been just a lot of different policies that have been taking place over the past 100, 200 years. We think that things are getting better, and they are somewhat better. But another example related to what Dr. Kane said, back in the mid 1930s, there's this thing out there called redlining. So the government actually had, in the mid 1930s, the National Housing Act at that time. They're trying to create more urban centers and suburban centers. So they at one time actually looked at different parts of every city and labeled them in terms of type A, B, C, or D in terms of their likelihood of being prosperous and being well for the community. And the type D community was one that said is decaying and doesn't have any future. And those communities were redlined. So the point that when they did that, the banks were given permission by the government to not give funding for those communities, not give mortgages, and if they do, they're high-risk mortgages. While that went away, the principles of redlining still exist today, where there's differences in terms of financial aid or the support given by federal, state, and local governments based on where you live. And vastly predominantly, these were in Black communities. And that directly affects our health outcomes for Black communities. The inability to get access, the inability to move up to get where they need to be is just been continues to grow. Another example of that, even in Indianapolis, our transportation system. I know we're going to do a different section on that. Our transportation is still pretty antiquated. For instance, all of our lines are north, south, and east and west. We don't have any. So if you're not on a bus line that's north and south and east and west, and if I order a test for you, you may not be able to get that test. So we talk about access. We talk about the historical policy that has been put in place has an immediate and direct effect today that we don't think about. It was not meant to be racist, but those effects have racist outcomes today. And we just need to understand that the history goes back a long way. And the way we need to move forward is to understand these policies and then truly make anti-racist policies with this top of mind.
Thank you. Senator Breaux?
Yes, thank you very much for the question. And I did want to go right along with Carl Ellison. I was quite ready to call you Representative Ellison. With Carl, to say that, in my opinion, this starts right at the very beginning. I like to start at the beginning of things, and at the very beginning of the formation of America, when we brought Africans into this country, we brought them into a foreign country, we brought them into a foreign environment, They then became exposed to all of these illnesses that were not part of where they were originally from, that now their bodies were no longer, their bodies did not have the built up immunities to be able to adjust to the foreign antibodies, I'll call it, that they were now exposed to. They were considered less than, so they were disposable. Now, one thing I find interesting is that the women, because they were the ones responsible for giving birth to the potential slaves, the future slaves, the women were well cared for, but overall, they were considered disposable, and having access to health care for these folks was not a priority. If they were able to get a physician out there to see them when they were ill, fine. If they weren't, then well, you know, we'll raise another one, and that one will take its place. Also, the onset of segregation, when we started having segregated hospitals. You know, the hospitals were separate and not equal. And so we began to provide healthcare services that were unequal and that were not on par with what others who were of the majority population were receiving. And so all of these things, America's historical blueprint is rooted in racism. And it's one that has continued to go to perpetuate itself year after year after year. One thing about the mistrust that I'm reminded of is that I did some work many years ago on trying to help folks understand the importance of organ donation. And I can't tell you how many African Americans were so sure that the physicians would let them die in order to harvest their organs, so that they were not willing to participate in organ donation programs. It's that mistrust, it's that misbelief that has been rooted in history that is the result of, it's what many men and women of color believe very passionately.
Thank you, Senator Bro. Our next question. Historical notions about race have shaped our scientific research and clinical practice. For example, experimentation on Black communities and the segregation of care based on race, and deeply embedded in the U.S. healthcare system, which has led to a long-standing culture of mistrust of healthcare institutions. What responsibilities do healthcare professionals have individually and collectively to understand the historical roots of contemporary health disparities? I'll start with Dr. Uwci.
Yeah, I think this is something very critical that we need to be addressing today and every day moving forward. There's still, again, people aren't necessarily racist, but the systems that we're in allows racism to occur and to allow those disparities to actually happen. I think from a medical professional standpoint, as we're trained, we actually are given, we are trained about how things are different based on your race. And that scientifically just isn't true. Racism is a societal construct that was made up and has no scientific genetic background whatsoever, but we weren't trained that way. You know, there's several examples in our medical training. We talk about kidney function, that, you know, Black Americans will have, we actually in our labs today have a different number for evaluating kidney function for Blacks versus whites. In cardiology, you know, we talk about high blood pressure and certain things that Blacks are more prone to high blood pressure because of that they retain more salt. These aren't true. And so the way we've been raised, and so it is embedded that there is a racial disparity when we're treating a patient. And I think what we need to continue to educate our fellow physicians and those coming out is that there's inequities, but it's not racial inequities, but there's inequities. And understand why there's inequities and treat the patient based on the inequities. There's no physician that's going to come out and say that I'm racist. But these implicit biases, we're trained to think that there's certain differences based on race, and we need to understand the definition of race. Race is actually something we made up. It doesn't exist in science, but a lot of physicians don't realize that. So I think we have a big challenge in front of us with something we have to tackle.
Thank you. Dr. Kane?
So Denise, I'm going to go back to that first question, then I'm going to add a little bit to what Dr. Uwci said. First, you know, the GI Bill. My father was in World War II, and that GI Bill was supposed to allow all the veterans that come home, that would give them housing. They could get a low-income mortgage to buy a home. They would give money to go to college and everything. And yet that was only for the white veterans that came from World War II, not for the Black veterans. So when you looked at the mortgages that were taken out by white veterans in New York and New Jersey, they had over 67,000 mortgages they gave out. They gave less than 100 to African Americans. And then, wow, so African Americans said, well, let me see if I can go to the historical Black colleges. Well, we were not able to handle the 20,000 Black soldiers for the GI benefits. So when you look at it from an economic standpoint, we had we didn't have a house. We couldn't build equity. We couldn't build that income. So way back in 1940s, we were already behind because it wasn't a level playing field. Now, Dr. Lady, I'm going to talk a little bit about precision medicine, because I do think there's certain medications that are based on your race. And I do think that hypertension has a little genetic disposition, because we see a much younger, for example, Black patients that have hypertension. But where we get the myths from our providers is, oh, you must not be having healthy habits, and that's why you have hypertension.
Absolutely.
Or you're not in compliance
Yes.
with your diabetes. I told you to do this medicine for your diabetes, and you got to do this diet. You can't have so much carbohydrates. And they don't have a clue that
Right.
there's no grocery store in my neighborhood. I can go to a gas station, but there ain't no fruits and vegetables in that gas station necessarily. So I'm like, you're a doctor talking to me like I'm some foreigner, because you don't even have a clue about my culture or my environment or how you should be educating me. So then you document in the medical chart, I've got a non-compliant patient, and every doctor after that says, oh, I've got a difficult patient I'm dealing with. So if that's not racism, I don't know what is.
If I could add one more thing to that. Just
Absolutely.
Sorry. I think, what Dr. King is saying is actually another very important about the medical profession. The number of Black physicians is abysmal. And I think to your point, Dr. Kane, is that you do get different treatment. If you're a Black patient seeing a Black physician, you're going to get a very different type of treatment and different biases that just aren't there. And that's not intentional. But that's another thing that's foundational. The past 200 years of medical education, we haven't provided for us to have more Black physicians to take care of the Black population.
Thank you both. Our next question. A recent study published by the Proceedings of the National Academy of Science showed half of white medical trainees believe myths like Black people have thicker skin or less sensitive nerve endings than white people. The more myths endorsed by medical students, the less likely Black patients would receive accurate treatment compared to white patients with similar symptoms. As a provider or a patient, have you had this experience? What other types of implicit bias fuels inadequate treatment of people of color? We'll start with Senator Bro.
Thank you. Yes, I have had a personal experience where I went into a hospital setting, and I was fairly young. I was probably in my 20s. So the physician probably didn't think I knew much to begin with anyway, but what I found really very insulting through the experience that has shaped the way I interact with physicians from this day forward was that he spoke to me, but he looked away, he looked in the air, he looked around. He never once looked me straight in my eye as an equal, as a physician to a patient, and as someone that was directly engaged with my own healthcare. And I had to set him straight. I had to let him know, listen, when you're speaking to me, when you were talking to me about my healthcare, you need to look me directly in my eye, because I am very involved in my healthcare. And what I found was that as I started to observe, I noticed that many physicians in the same environment that I was in, that had a number of African Americans as their patients, just assumed, I think, that they were not up to the task of understanding what was being discussed, and that did not really understand their healthcare. When in fact, I found that we're very, very engaged. I had a friend who, and again, about the myths of what we can and can't, it's right there with what Dr. Kane said. I heard an anesthesiologist once who was in the delivery room with a woman complaining about the fact that this woman, you know, why are these poor mothers on Medicaid always so obese? Well, again, without any understanding of the fact that perhaps this woman doesn't have access to healthy foods. And so the only foods she can eat are foods that are going to result in her being obese. And that when she gets pregnant and gives delivery, she's going to be overweight. The belief that we are non-compliant. I've overheard conversations where the physician has indicated that they have a non-compliant patient, as Dr. Kane indicated, when in fact they simply don't have access to the resources to purchase their prescription medications, or perhaps there's no pharmacy available in their neighborhood. Many poor communities of color don't have adequate pharmaceutical outlets to even purchase. And then my last example is one where a young lady was giving birth and they felt that she did not need epidural. She gave birth, she calls this the most traumatizing delivery she's ever had, but they did not give her any kind of medication to aid in the delivery of it. And she did it all without any medication. And that was, they just, for whatever reason, did not thought she was tough enough. She was out of the Army. She was very well developed from her muscular system, and they just assumed she didn't need it. And so, you know, it's things like that that contribute to the sort of the misconception and the distrust that we have of the medical profession.
Thank you. Dr. Kane?
So I think you just saw that information about what's considered the father of modern gynecology, Dr. Sims, who did surgery on women at that time who were considered, I guess, property. He did surgery on them unnecessarily without anesthesia because of what you're saying, that thickened nerves. So some women had painful surgery where they were cut into, and learning how to do a repair with sutures and instruments like that. You might as well say it was the same as what happened in the Holocaust in Germany when they were doing inhumane experiments. So the fact that we could do that still in this country has been, it's just been appalling. And that was more recent in terms of those surgeries that have occurred.
Absolutely. We have an audience question, and I'm going to pose this to Dr. Uwci. How can we find out the healthcare providers who take the health of Black people seriously and support them in their practices? What are some of the subliminal signs we should look for to determine whether our healthcare provider is not taking our healthcare concerns seriously?
That's a very challenging question. I think one of the things that I think is important is actually to interview your provider before you see them. For instance, Community Health Network, we have videos for most providers you see online. Talk to friends about it to really understand if the provider understands it, and see it. At the end of the day, even if it's not racial disparities, you obviously need to be able to trust your doctor. And so, however, to build that trust, you need to take certain actions. And probably one thing that a lot of people don't do because of the system is that they don't fire their doctor. So if you're with a physician, you feel intimidated saying that if you don't click, that you'll still stay with them, and it's okay not to like your doctor. That we're all human beings, and say people. It's not that you're good or bad people, good or bad doctors, but we have different ways how we interact with each other. So I think it's a trial and error, talking to your friends and then doing interviews with the physicians. One thing I do want to step back though is that one of the things that several people talked about is this concept of people not taking care of themselves, and that they're. One thing I tell all my physicians is that there's no such thing as a patient that doesn't want to get better. So you can't, the term non-compliant patient in Community Health Network, we really try to ban that word from being used, and it's still used. I don't see that such a patient existing. Non-compliance means there's some underlying issues why that individual cannot be compliant. And to simply write it off as non-compliant is to take the easy way out, frankly.
Thank you.
So I think for me, it is, I think it's the ability of that physician or the provider to listen to you when you're talking with them. If you have a provider that wants to make all the decisions, and you can tell they don't really value your input, because this is a joint decision making. What happens to you, a lot depends on what your feelings are, what your concerns are, and if you're having pain someplace and you say, no, you're not having pain there, you have to, over time, you may not always be able to tell them in the first visit, but over time, you may have a sense of, can you tell this provider really respects you as a person? And so it helps to make the decisions, or are they tuning you out and they already have pre-biased decisions about you in terms of making the recommendations. When I go to see doctors, unfortunately I can't do it now no longer, but I wouldn't tell people I was a physician, because I wanted to see how they would interact with me without knowing that I'm a doctor. So I think some were shocked and surprised sometimes with my responses when they would say something to me. And then I think the second piece that's really critical to understand, that sometimes doctors will give you mumbo jumbo. What do I mean by that? They try to talk so far above you from a technical standpoint, it's implying that they really don't want to have a communication with you. So it's sort of like an intimidation game. So if you've got a provider and you can't understand what they're saying, hey, you need to find another doctor.
Thank you all. Our next question. How has systematic racism been institutionalized in healthcare and health policy at the federal, state, and local level? How does that impact decision-making, access, implementation of healthcare? And what state policies are the most harmful in perpetuating health disparities among African Americans in Indiana? I'll start with Senator Bro.
Health, it's the result of an establishment of patterns, really. The establishment of a de facto sort of segregation of hospitals. So for example, all I can think of is Wishard back in the day was considered a hospital where if you had Medicaid, which typically meant you were poor and Black, then you went to Wishard because Wishard accepted Medicaid. Whereas some of the more affluent hospitals, perhaps in other parts of the city, were not seen as Medicaid accepting. And so it was the establishment of the pattern of insurance that led to the systematic racism in hospitals. I had some information provided to me earlier about various types of tests that physicians have where the logarithms associated with them are based in bias. For example, the removal of kidney stones. Folks who were of a non-minority background had 3 points assigned to them, whereas minority folks did not have those 3 points. And so that meant that when they did the final scoring of the removal of kidney stones, physicians would be less aggressive with those patients that had a lower number. And because Black folks weren't given the automatic 3 points to start off with, their numbers were lower. So there are all sorts of systematic ways in which it's embedded into a system, whether it's a conscious embedding or not. I don't know. It's hard to sometimes tell. But again, it's the whole belief that that there is a difference, and that difference is based primarily on race as opposed to anything else that's a legitimate reason to look at differences.
All right. Dr. Kane?
So I would tell you that, Black infant mortality was one of the highest issues and still remains a major priority in our community. And maybe about 5 or 7 years ago, our state legislators made a decision to remove what's called presumptive eligibility for pregnant mothers for Medicaid. So what does that mean? Currently right now, because we have to put it back in place, you can come to a doctor's office, you don't have the insurance yet, but as long as they apply for the paperwork, that doctor can be paid going back at least 3 months from when you get your insurance finally approved. Well, they removed that presumptive eligibility. I'm not sure quite all the reasons. So what happened? We had a dramatic number of our providers refuse to see pregnant mothers who were Medicaid eligible. So we were having low reimbursement already to take care of our pregnant women and women low income or have no insurance. And so providers said, hey, I'm not even meeting my costs to take care of these pregnant women, so I'm not going to see them. So we saw our infant, all that great work we did and advances we made in infant mortality, we saw it shoot right back up because we couldn't find providers to see these pregnant mothers, and they were being seen late in their pregnancy or just near their delivery. But that took 3 years to finally have that better understanding by our state legislators to finally reverse it. But it takes a longer period of time to bring those providers back now. So this is where health policy can have some major implications for us, and it's those unintended consequences that we always have to be cognizant of.
Dr. Yoleti?
Now, in terms of systemic racism, how that can institutionalize, there's two things that come to mind for me. One is the fact that it's still in the United States of America, the type of insurance you have is still dependent on your job. Yes, we do have the Affordable Care Act, we have Medicaid and so on. But for people, if you have a higher paying job, you will have better health insurance. And so, you'll have better health care because of your health insurance. Simply stating of health insurance isn't the full story. What kind of insurance you have as well. So the fact that we still tie your ability to have access to health care to the kind of job you have, I think results in systemic racial inequities in terms of outcomes. The second thing that I think we need to address is from a CMS, the Medicare for the United States. They have, the Institute of Medicine many years ago have recommended, we still have not instituted, looking at health disparities based on race and then specific actions related to that. There's a lot of work regarding what we call value-based care and what we call managed care contracts and so on. But we don't have robust data about racial health inequities the way we need it throughout the country, by hospital, by physician, by region, which is a big undertaking. But again, one of the systemic issues we have is we don't have the data that we need to actually make definitive changes, so that we can actually see are the changes real, are they long lasting?
Okay, thank you all. Our next question. There is a belief that African Americans are to blame for their own poor health outcomes. Is there any truth to that? Where do you think that belief comes from? We'll start with Carl.
Well, I don't know where to start on that one other than to say that is an absolute racist myth that's designed to put the onus on the victim, not on the system that provided the environment which helped to create the adverse health outcome. Now, the audience should already know, but maybe they don't know, so let me just say this. If you take the beginning of life, infant mortality, as Jenny and others have talked about, Black babies die at 2.5 times the rate of white babies. So we have health outcome difference on the front end. When you go on the back end, when you look at life expectancy, but for Black men versus white men, there's at least a 5-year difference. That gap has existed for as long as I can remember. I don't know how far back we can trace the data. So if we are dying more at the front end of life and are dying sooner at the back end of life, and as Ram and others have said, there's no theoretically genetic reason for that. It's clear that this is just a way for a racist system to pretend that somebody else, this victim, is at fault for their outcome. Now, I will say this, we've often will target people of color for prevention interventions. So take diabetes prevention, for example, where we'll do programs to try to adjust lifestyle and teach how to eat and all that. And sometimes we're successful in precluding the onset, for example, of diabetes. But that's sort of a person by person, community by community effort. It doesn't change the fact that the person that you're trying to get the diabetes education to may well go back into a home where they have those food deserts that Jenny talked about, or that may not have the capacity to know how to read those labels in the grocery store. And so there are just systemic barriers that have been in place that the system pretends are not there. When you just talk to people at the local level, at the community level, they can tell you. I mean, everything I'm telling you should not be news. It's just part of the fact of life in American society that we are not equal, we are not unbiased, we are not colorblind. And when it comes to health outcomes, the context in which we live provides assurance that we will get the health outcome disparities and differences we continue to experience in this society.
Thank you. Dr. Uwci?
Yeah, unfortunately, yeah, that your comment about that belief, that is the root, that is racism. To state that based on the color of your skin or your ethnicity, you are going to have worse health outcomes. And so that is the root of racism. I think one of the things people believe that for several reasons, but I think one is that, you know, people don't want to be called racist. And I think people understand that racism or being racist does not need to be a label about who you are, but the behaviors that we do or the systems that we're in. So it's more about the systems and the policies and the individual behaviors we have. And I don't think people want to label themselves, and you don't need to label yourself. It's not a personal issue for you or anybody else to state that, but understand. And then the second problem with that is then people think, well, if it's not due to their color of skin, the problem becomes too big for them to handle. They become overwhelmed and they don't understand the systemic fundamental issues with this. You know, for instance, to tag on to what Carl was saying about the end of life, Black individuals die from cancer at a much higher rate. And one of the reasons for that, frankly, is that Black people are afraid to go to the doctor early. So you're not going to get your mammograms, your colonoscopies, and so on. You're afraid of the healthcare system based on what they've done to you before. And so to kind of lump it together, saying that Black people are generally unhealthy, it's just an easy way, kind of almost like a cop-out. But I think what that needs to understand is let's get data and let's talk about what are the systemic policies we can change. And hopefully if you start having a different conversation, it's still a hard conversation, but it's the right conversation to have.
Thank you. Dr. Kane?
So I think when we look at health outcomes, you know, we look at the racial disparities, but I think the big elephant in the room is the economics, okay? When we're looking at it and impact. Carl knows what I'm talking about. We used to have these conversations a lot when he was at Memorial Hospital in South Bend. So think about it. If we look at the chronic, if we look at racism that people of color have faced, that's like post-traumatic stress disorder, honestly, because I'm having chronic racism, the stress related to that. I've got that fight or flight aspect where my body's responding and it's in high alert and it's putting out these stress steroids. But over time, because your immune system is, you know, accelerated, it's like I got my foot on the pedal all the time. When you do it chronic over time, it can have damage related to you. But when we look at African Americans, our poverty rate is about a third of the percentage compared to our white counterparts. So when I have to look at, wow, I don't have any insurance, so I'm gonna go pay for my medications at the drugstore. And that one medication, just 30 little pills, costing me $250, and you say, are you crazy? $250 for just one pill, for 30 pills a day? But so low income folks who don't have insurance, they don't have the luxury to even pay for medications. And you wonder why they have a poor health outcome, especially if they have one or more illnesses that may require medications. Or they got to worry about putting food on their table, pay for their rent, haven't helped them if they've got to figure out childcare. And so if we look at the social determinants of health that we need to address for our patients, if we don't address it, of course, our health outcomes are going to not look as favorable as someone who has money, resources, education, they're not health illiterate. They're going to always have better outcomes than those issues. And unless we are able to address social determinants wholeheartedly, I'm not meaning just, I'm going to tap you here, I'm going to refer you to that, and you figure out how to do that on your own. We can't, that traditional medical care is out the window. It's got to go. It should have been gone. We should have kicked it out a long time ago.
Thank
But
you.
if we really want to address health disparities, we got to do wholeheartedly
A holistic.
social, holistic, addressing the social determinants.
That's right.
Thank you, Dr. Kane.
I could just maybe add one last comment to what Penny was saying. So I think that's exactly right, is that, there's kind of a double whammy of being Black and the socioeconomic class and being poor. And I think people still have the belief that Black people are poor and they just aren't going to get out of it, that's their problem. And the people don't understand the systemic issue that you're referring to, Dr. Kane, about it's not, nobody wants to be in that position. So you really need to understand the fundamental issues. A while back, several years ago, there actually was people would actually state immigrants from Africa were better off than Black people in the US, and they thought that those were better bloodlines and they would actually discriminate. And the point there is that it took a lot to come out of Africa to come here. So you automatically, immigrants were at a different level because they were kind of chosen to come here because they went through all the hurdles. My point being is that we still continuously assume that being Black and poor is one and the same, and that they do it to themselves. And I think you reinforce, the fact that that's not the case, and we need to understand the foundational issues for society, and not based on skin color.
Hey, Denise, I just got to say one more part. I'm sorry.
Briefly,
Dr. Letty, you shouldn't have said nothing, okay? So do you know what our minimum wage is here?
Right.
Our minimum wage is $7.25. That minimum wage has been there for 20 to 25 years. It has not risen. And yet inflation is going all over the place. So how do you expect someone who's making $7.25 an hour to make it? They can't make it with that amount of money. We need, as a community, as a state, I'm talking out to you state legislators. Hello, Gene. Hello. We have got to raise the minimum wage. We got to raise our minimum wage to living wages. This is where health policy, this is our community. We talk about responsibility. Give someone a living wage. That just means basically I've got rent. I can keep my lights on. Yeah. I've got food, and if I have to, I can do some transportation. Okay.
And some kind of universal health care, so they don't have to depend on their employer to provide them health insurance. Because at $7.25, they either can't afford it or they're not getting adequate health insurance to cover them anyway.
I'm going to step in here.
All right, okay.
All right, in lieu of time. So we're going to transition to talk about COVID-19. Has COVID-19 revealed new health disparities, or has it brought to light health disparities that impact people of color that have not been addressed? What are the barriers to addressing these disparities? And on the screen, we can see there's on the screen some data about COVID-19. And as many of us know, that African Americans and Hispanics have contracted COVID-19 and are dying at higher rates than their population as well.
So can I answer this one too a little bit? So that's Indiana data, but Marion County, because we have a higher population density. We're almost 28% African American for Marion County, and we're about 15% Latino. So we've seen a greater percentage of Latino or Latinx populations in our African Americans making up our COVID-19 cases. So easily we're up there making almost half of our cases that are Latinx or African American. So way much higher than that state data that you've seen. Mm-hmm. And so, we've always known we've had these health disparities. We've had these issues, but wow, COVID-19 has been like an explosion. It's all of a sudden magnified. You can't see it hitting anymore. It is there for everybody to see.
Yeah.
Dr. Letty?
It's hard to kind of top what Dr. Kane just said, but it actually raises the facts. Again, I talk about we don't have data. People are seeing the data now. It's right in front of their face. We need to address it. But even then, we still have racial disparities and we still have racism. For instance, one of the complications of COVID-19 is you have blood clots that go to your feet. So we call them pink toes or white toes, but so that's in white people. So even today, the way the medical literature, and it's not intentional, but this is implicit bias in how we do things, we don't understand the true issues and how do we take care of them. So it is very apparent. And I think probably the only good thing to come out of it, just to echo what Dr. Kane said, is that it really raises the awareness of it. So hopefully people start asking more questions. We don't necessarily have to have the answers, but let's start asking, why is that the case? What do we need to do differently? What policies? So hopefully there'll be more conversations based on what we've seen so far.
Now, let me just jump in and say the State Task Force on Health Disparities that Gene served on, Senator Breaux and myself, what we found was essentially several things. First, we don't have good race ethnic data. That chart
Yes.
that was up is, I'm ashamed of that because we should already know the
Right.
race ethnic portions of how this virus is impacting race ethnic populations. So we don't have good race ethnic data to be able to know the problem, let alone then to figure out how to best strategize, how to intervene, et cetera. Secondly, in our report, we looked at various policies which ought to be considered for change. That, for example, in the prison population, if you just reduce the size of it, you reduce risk. If you got rid of cash bails, you reduce risk. If you simply had a way to track where people were tested or not as they went through the criminal justice system, that would be helpful. On the maternal child health side, we talked about earlier, little things like extended prenatal care so that it's postpartum for a year, making sure doulas can be in the birthing room, things that we know from a research point of view would help populations of color. And so we put together a whole number of recommendations for the legislature to consider that frankly get at just common sense ways to better allow us to address racial disparities that really have been brought to bear by COVID. And what I worry most about with COVID is not what we see now. I worry that we don't have the data to know what we're going to be seeing if we get that second wave. And so we've got to work harder to get better race ethnic data across all health concerns as rapidly as we can get it.
Thank
Well,
you. Senator Breaux, I'm going to ask you can you limit your comment to 30 seconds or
well,
less,
yeah, well,
at least a minute?
Again, I think it just exploits
Thank
the socioeconomic factor that we've spoken about, because many of the folks who are contracting COVID are in the low echelons of society in terms of their entry-level positions or their food processing jobs. And it just again shows that when you're in those vulnerable spots to begin with, you're at a higher risk, higher capacity for these kinds of medical situations that are just unequal when it compares to others who are in a better position financially and economically.
Thank you. We're at our final question.
Uh-oh.
I know. It's really fast.
We
Looking
needed 2
forward.
hours.
I know, 3 probably. Looking forward, what are some of the solutions that United Way of Central Indiana and the community can champion to address racial health disparities? What else can and should be done to improve health outcomes? We'll start with Dr. Giletti.
There's several things, but probably 3 things that come to mind. Carl alluded to one of them. First is we need more data. Anything we can do to force data. We need to understand what we're dealing with so we can attack it, and then we can actually measure, are we actually making an improvement. The amount of inequity data is, and Carl already went through it, so a lot more robust data at a local, state, and national level, I think is critical. Second is just broad education. Some states are now mandating implicit bias training for the entire state, for instance, the state of Michigan. So I think understanding that we actually have an issue, because a lot of people, frankly, don't think this is an issue. A lot of my own colleagues don't see this as an issue. So letting them understand why this is an issue, educating people about why this is an issue and implicit bias, I think is critical. And then thirdly is continue to attack the underlying socioeconomic status and funding. I think money at the end of the day is critical to this. And I think we need to make sure we support our legislatures in terms of how do we better fund these socioeconomic discrepancies that we see.
Thank you. Senator Breaux.
Well, again, just understanding the underlying relationship between poverty and health outcomes, the poverty and the ability to get a decent meal, to be able to pay for your medications, to be able to have a job where you're not at risk. I think we need to understand poverty and try to figure out all the ways that we can to alleviate poverty and to increase the standard of living for all of the folks who make up the residents of the state of Indiana. And in particular, those that tend to be on the lower end and are oftentimes left behind when decisions and policies are being made. So there needs to be a focus on understanding the impact of poverty on the lives of all of our Hoosiers.
Carl.
Well, I think particularly for the audience here and sort of give a call to action, what I would say is begin to assess your own organization through a race ethnic lens. Look at government staffing, policies, programs from the point of view of race and ethnic populations. Are these policies, the things you have in place, do they harm, do they hurt, do they help, do they not? So you've got to begin to look at things through a race ethnic lens. Secondly, cultivate a corporate culture where bias resistance is taught, it's trained, it's drilled, it becomes part of the corporate culture. But I think the most important thing that leaders can do is call out injustice when you see it. It is foolish to me that we have, for example, predatory lending, and United Ways have been very, very good about pushing against that. But that's just legal exploitation of the poor. So when you see things that are clearly unjust and adversely impact poor people, corporate leaders and organizations, I think, have an obligation, if they're going to be part of the fight here. You've got to get out your comfort zone. You got to be willing to speak out. You got to call out injustice when you see it. And then you've got to sort of be a drum major for justice, like Dr. King talked about. And you got to put your money where your mouth is. If you really want to help out this, it's not enough to fund the program. How about some loan executives? How about some multi-year commitments? How about something to help develop greater capacity at the community level to address these folks out here who are part of what United Way organizations typically do, but how about helping us more robustly help these populations through minimum wage increase or whatever to help them actually achieve greater economic stability? If you can just improve the economic circumstances of people of color and poor people in this state and nation, I think we'd see enormous productivity, we'd see enormous peace, we'd see enormous progress. That's the American dream that they can help us achieve.
Thank you. Dr. Kane, 1 minute.
Oh my God, this was just so hard.
I know.
Let me just tell you this.
30 seconds.
First of all, I really have to commend all my colleagues. You guys were just fantastic, and I just appreciate everything. Dr. Uwci, when I couldn't get COVID-19 testing, Bob Baker, your infectious disease guy, would always squeeze patients in for me and test them for me. So I just got to give you kudos, and I got to shout out to him because he was the first person that helped me out when I couldn't get testing for my patients. But philanthropy, United Way, the people who are in this business, let me tell you, you've done a remarkable, tremendous job because, Carl, you said we're concerned about waiting for the first peak. Hey, our stimulus dollars are going to end July the 26th. And I don't think Congress has signed that second stimulus bill yet. So if it wasn't for organizations like United Way, our philanthropic foundations, our Chamber of Commerce, we've got to keep these people from being put out of their places so that I've got this increased number of homeless that I've got to worry about in the folks that are incarcerated. So we need leadership from everybody, but we need accountability. So you got to have some measures in place from a diversity standpoint to say what you are doing. And if we can keep up with this incredible leadership from our community, and I have to compliment Mayor Hotsett for helping to put a number of things in place, but every foundation here that stepped up to the plate, my God, thank you. Continue to do the good work. And have us all come back, say in 6 months, and let's know how we all faring now.
Thank you, Dr. Kane. Thank you to each of our panelists tonight, Senator Breaux, Dr. Kane, Carl Ellison, Dr. Uwci. I thank you from the bottom of my heart. This has been an honor to moderate this panel with you this evening. I would like to thank each and every person that's tuned in right now for joining us today for our first introduction into our series on understanding the roots of racism. It is our hope that each of you have learned something new today and that you will have something to take away to teach someone else. Please know that you will receive an email with additional resources as well as a link to register for the next presentation in the series. The next series will take place on August the 19th. That's our second installment, and it will be centered around housing. You will also get in a future email a link to this presentation. Thank you, everyone, and have a great evening. Good night.
Thank you, everyone. Thank you, Denise.
Thank you.
Thank you.